Nick Bajerison here. Welcome to Top Med Talk. Time now for one of the talks taken from EBPOM 2018, hugely successful conference that happened earlier this year at the Institute of Engineering and Technology. And this is a piece taken from the lunchtime lecture sponsored by Edwards Life Sciences. It's Monty Mythen and it's called Cause and Effect. Have a listen.
Top Med Talk. I'm really delighted, another lunchtime session sponsored by an industry partner, this one very generously sponsored by Edwards Life Sciences. And we're going to be talking about blood pressure in particular, and some very, I think, exciting developments in the prediction of hypotensive episodes using artificial intelligence, machine learning. And it must be real because relatively recently it appeared in the Wall Street Journal. So, proved in Europe a reasonable time ago now, the use of an Edwards technology to allow us to have a greater understanding of when blood pressure drops may happen, particularly in the perioperative period, although it has utility elsewhere, and very recently approved by the FDA, but under two slightly different titles, so we'll probably abbreviate it most commonly to HPI. So I'm just going to very briefly remind you about why we think hemodynamic instability, particular hypotension, is important. Among my conflicts of interest, I do consult for Edwards Life Sciences, and this, just to be clear, this is a sponsored lunchtime session, so we will be specifically discussing Edwards technology. So if you are tempted to go to Top Med Talk, which I've been referring to, and you go in there and you go to the search engine, and within the search engine you type in Sessler, S-E-S-S-L-E-R, you'll get a number of recordings, interviews from Dan Sessler. This one, for example, recorded at the ASA in Boston. The elephant in the room, intraoperative hypotension. And the other one, low blood pressure during surgery associated with shocking outcomes. I'm going to play you 3 minutes of it, where Dan Sessler goes over and over again the fact that there is a very clear association between transient periods, so as little as 1 minute of a mean arterial pressure of less than 65 has been associated with very major outcomes. He also goes on to discuss, hang on a second, we mustn't get overexcited about that from the point of view of it's an association, and from the point of view of the fact that 1 minute doesn't mean you're going to have a bad outcome, it just means your risk of a bad outcome is greater.
Top Med Talk.
Okay, surgical wards have been a concern of mine for a long time. We take care of patients exquisitely carefully in the operating room. Then they go to a post-anesthesia care unit where they essentially get ICU care for an hour or so. And then they go up to surgical wards, and it's like the Wild West out there. They get vital signs every 4 hours, if they're lucky. Very often, it's a nurse who just writes down a number, even if it's quite abnormal, and nobody does anything about it. Heart attacks occur post-operatively. They do not occur intraoperatively. And so I've been very worried about post-operative hypotension. We didn't have good data until recently, but we just now have some data. We have 200 patients with continuous non-invasive blood pressure monitoring for 48 hours after surgery. And what we see is that hypotension is common, profound, and prolonged. Lots of patients who had non-cardiac surgery go to surgical wards and they get hypotensive. They get quite hypotensive and they stay that way for a long time. Take for an example, about 10% of patients have 15 continuous minutes with a mean arterial pressure below 65 millimeters of mercury. That's a low pressure even in the operating room, and post-operatively I'm quite sure people need a higher pressure. The nurses missed half of these episodes.
And that is, the Cleveland Clinic is, we think, an extremely good place, well-resourced place, etc. So goodness only knows what it's like in our sorts of places. Mike, do you have any feel or data on that? You look after a lot of post-op patients. Do you think the ward is just unknown?
So I don't have data from our institution, but I find what you're saying entirely credible. I mean, from experience, we do come across patients where the nurses who, certainly in our context, are overpressed. They're looking after a large number of patients, and we have patients who it would not be a surprise if they've been hypertensive for quite a long period of time, but they've had measurement maybe every 4 hours.
And we're not. No one's blaming the nurses or anything here. That the paradigm that we live in is the Q4 blood pressure once they look okay post-operatively. Tim, any data from Duke? What goes on there? Is this a known unknown?
Yeah, no data, but I entirely support what Dan says. I think that it is an unknown. We need to investigate it more, and I think ultimately we probably need more intensive post-operative monitoring for a lot of our patients than we currently have.
So Dan, last couple of minutes, what next? What are we going to do about this?
Okay, well, it's not just hypotension, it's also hypoxemia.
Okay.
Hypoxemia on surgical wards is also common, profound, and prolonged, and the nurses miss 90% of serious episodes. The only way we're going to solve this is with continuous ward monitoring. And 10 years ago, this would have been impractical and impossible and too expensive, but that's not true anymore. There are now battery-powered wireless devices you can put on patients. You can get blood pressure continuously. And the values need to go into a smart system. I'm not saying that somebody has to sit there and watch every one, but a smart system can identify the one patient in 10 who's getting in trouble. Somebody can look at that, alert things. In the previous generation, we were concerned about failure to rescue. But that's the wrong paradigm for the future. The future has to be preventing crashes. We don't need to wait until people crash and then try to rescue them. We can prevent the crashes.
So do you think for that, do you think that we need the evidence, if you sort of mean, to get on and do what sounds like the right thing, or do you think we're just duty-bound to get on and do what sounds like the right thing?
No, we absolutely need the evidence. We desperately need a large randomized trial of blinded versus unblinded continuous ward monitoring. And it will not change. Hospitals will not adopt this. Nobody will pay for this until there's evidence. But if you have a large randomized trial and you show that continuous monitoring saves lives, then there's no excuse.
Top Med Talk.
Play it to your friends if they don't believe that's what he really said. It comes from this type of observational data that I shared briefly for those of you in the room yesterday, where they've taken the big data at the Cleveland Clinic, and you can only see this if you have very big data sets. And they've looked at the impact of a transient period, and here they show 1 minute, 3 minutes, 5 minutes, and 10 minutes, of a blood pressure below a mean of 65 during the conduct of major surgery at the Cleveland Clinic, where I'm guessing people get looked after pretty damn well. They didn't seem to be short of a few bob there when I visited. And the subsequent likelihood of the patient developing either MINS, this, let's call it a mini heart attack, or in some patients' papers, a major heart attack, or on the right-hand side, as you look at it, the probability of acute kidney injury. And as you might expect, the lower and the longer, the greater the risk. That's bound or obvious. But to us, we're all sitting around saying, hang on a second, you mean 1 minute below 65 increases your likelihood of having a heart attack, a stroke, dying, developing acute kidney injury? Well, we've always taken hypotension seriously. Do we think we may have allowed patients to drop below 65 for a minute? The other disturbing thing is many of these events occur between induction of anaesthesia and surgery starting, i.e. knife to skin. So there's only two people to blame for that, really. That's the patient, shame on you, okay, or us, who pushed the drugs and or didn't treat the blood pressure or didn't give the volume or didn't give the whatever it is. So sobering stuff. Showed you this yesterday, various different hemodynamic algorithms that we have and share. And they always include within them not only volume, but the use of vasoactive agents to either change afterload in the middle section here or contractility. So that's the way we believe we practice. I also shared with you the fact that relatively recently published in JAMA is a prospective randomized controlled trial, a multi-center trial from France, where they have treated blood pressure intraoperatively in one limb. Once they fix the volume, they then treat the blood pressure with an infusion of norepinephrine to maintain the blood pressure within 10% of the preoperative systolic pressure. And when they do that, in this multi-center trial, outcomes are better. So in the bluish bars, blood pressure in around 300 patients, higher for the duration of surgery, and outcomes using this composite outcome variable, where being on the lower line here, I misquoted this yesterday, the individualised treatment is the improved outcome. So a statistically significant improvement in meaningful outcomes, a p-value of 0.002 published in JAMA, it must be true. So therefore that really is also attention to detail, hemodynamic management, but in particular once you've done the stroke volume optimization, giving an infusion of norepinephrine to maintain systolic BP seems to be associated with improved outcomes, and I don't think any of us would be surprised by that. As I emphasised, volume treated first, then it started. When you look at the more recent hemodynamic management trials, and I quoted Fedora, most recent published that I know, a 420-patient multi-centre randomised controlled trial published in the BJA out of Spain. If you look at their algorithm, again, it has multiple treatment points within it. And specifically, once they fix the volume, the next two important variables they look at is cardiac index and mean arterial pressure. So in this trial, again, they are focusing on that map of 65 as being a trigger point whereby once they fix the volume, if they think the cardiac index is adequate but the map is low, they give a vasoactive agent, or typically norepinephrine again and mixed alpha-beta agonist to maintain that head of pressure. And we know the outcomes are improved in that as well.
Top Med Talk.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.